Okay, that is all. We'll now proceed with round one of DADC. The motion is this house will allow terminally ill patients to access experimental drugs and treatments that have not yet completed safety trials. Okay, without further ado, I invite the first speaker of side proposition to give their speech here.
Hey, am I audible and visible? Wait.
You are not okay, you are visible now.
Okay, so my speech will start in 3, 2, 1. Judge, when death is certain and experimental treatment is the only remaining possibility, the question is not about whether perfect safety, but about whether we would allow this chance and hope for the patients. Before with my argument, I would like to start with a few pieces of framing. One, what do terminally sick patients actually look like? They often suffer from an irreversible and painful sickness. There are no existing approved treatment that can cure them. They are in deadly condition most of the time, and time is often extremely limited. They're really desperate to recover, so therefore they will be willing to try any possible cure that sounds reasonable. Then what do experimental drugs and treatment that have not yet completed safety trials look like? One, there will be side effects. Treatment didn't go through a full safety trial doesn't mean that they didn't go through any. So it's not a complete blind test. But we know that there will be a certain baseline level of confidence in the drug, but it just needs some refined development. And why are companies incentivized to have these basic safety trials? Because one, there are a limited number of patients. Killing them all with just fresh drug, not tested, no safety baselines, will just destroy the credibility and lost the amount of people who may help to develop these treatments. They should have a base and refined version on the patients rather than just starting straight up with them. Then it's easier for the companies to tune and edit when testing on a based certainty. Less guessing in development, which means more certainty. Last, it was a reputation problem with the companies wants to seem like they are benefits to patients, right? So they will, one, get more patients to opt into these treatment. In this case, by guaranteeing them there will be a certain extent of safety. Second, getting the investors to see that there is a chance of successful rate. It's just not a handful of patients suffering from an unstable base. So these investors want the immediate benefit from supporting these companies and see the progress. Therefore, it's best for the companies to present a ready trial treatment over an unstable early stage one. Next, what is the difference between experimental drugs treatment and regular treatments? As we have told you, these people are desperate for a cure, but they have already tried most procedures already. So they either have too advanced conditions for existing treatments, for example, cancers that chemotherapy cannot heal, they have niche conditions with small advancement into, or it's just too rare for current medical focus, which means they have exhausted all their existing options and experimental treatment is not an alternative, it's the only option left for them. And last, the companies will only provide them to terminally ill patients because, one, they want to show that they're exclusive and special, distinguish themselves from others in order to gain more sponsors and investments. They're looking for the profit. That's what all companies want to do. Then, as they opt for more terminally ill patients, it will have less of a negative impact if the drug doesn't work out, as they are in deadly conditions already. But when they do somehow develop a cure, it will be a medical miracle, which bring in tons of profit and reputations. Last, it's easier to show terminally ill patients that this cure is exclusive and better than the regular ones, a chance for recovery, and even if they're at risk because they have no other options. Now moving on to my first argument about recovery and hope. They have a chance of recovery because this treatment will work. They will work at least a little bit because there have been basic level of testing around these treatment. They have not yet passed the safety trials, maybe because of factors like time, cost, or scale, not because they're ineffective, so they will be guaranteed effects. For terminally ill patients, even a small chance of success is meaningful when the alternative is no chance at all. Note that patients only choose these treatment because they trust the institution providing them. That means these hospitals and companies with high reputation cannot afford the public backlash for misinformation, and any serious harm or fraud they may result in lawsuits. So this creates a strong incentive for the companies to stay honest and provides clear details and information. This development would be new and significant, which means with companies incentivized to develop this treatment to best fit the best of their abilities, the companies will have shareholders and investors who need to see the ability to show real medical breakthroughs. So they will try to gain real achievements as they have the company reputations to keep up. And terminally ill patients as a unique market, the families will definitely spend a large amount of money to get this scarce chance as a scarcity. The company know that there's a high demand for this treatment, so if they develop it due to its scarcity and exclusivity. This high demand creates strong financial incentives to continue improving these treatments. We're not forcing this upon them, but rather giving them an option, an opportunity to escape from the pain, even if it's at a risk, because they are already desperate in need of cure. Terminally ill patients are capable of informed consent, and doctors will clearly explain the risk, uncertainties, and possible outcomes. And patients can choose freely whether the potential benefits is worth the risk, preserving both their autonomy and dignity. Then it's an informed choice, so there's no different from chemotherapy. Chemo is known to have severe side effects such as organ damage, yet society still allows this because the potential benefits definitely outweighs the risk. Prior to framing, we know that these drugs will do, and the medical workers will make sure to inform the patients, as this issue is highly sensitive to the patients and their families. So if there's any misinformation or bad treatment, they will get a public backlash, which means there's no different from the established treatment. It's not like no safety trials completed means no trustworthy and credible organizations. So the approach of these organizations take won't be far from the established treatment. Therefore, experimental treatment will work the same because the risk is justified, and we know the alternative is best for the patients. Last, this is still and always the best shot at life for terminally ill patients, because denying experimental options leave them with no medical pathway forward, while allowing access to give them at least a chance. And then now moving on to my impacts. This argument directly impacts whether terminally ill patients may get a chance to live longer or just die sooner. Even a small chance of recovery outweighs the procedural safety concerns to an alternative result for those who cannot wait. And last, moving on to my last few pieces of weighing. One, this is guaranteed harm versus potential harms. Opposition denies the access to protect patients from side effects. Their denial guarantees death and no chance of improvement. The potential harm from side effects of experimental treatment cannot outweigh guaranteed death on opposition's side. Even if we take our worst case and say there's only a small chance for a cure, it's still better than opposition's world. At least we can save a few terminally ill patients, while there's no chance at all on opposition's side. The recovery. And then for the patients, opposition removed a choice just for safety, while proposition protects these and informed. While proposition respect informed voluntary decisions by competent patients. And we believe it's more harmful to deny a patient's choice and agency than to allow them to take a risk, which is fully understand before they really opt into. Last, Judge, I just want to say that safety without survival means nothing. And this is why I'm so proud to propose. Okay.
I thank the first proposition speaker for their speech. I now call upon first speaker of opposition to give their speech. Here.
Hello, may I check that I'm audible and visible, please?
Yes, you are.
Okay. Okay, I'll be starting my speech in 3, 2, 1. Firstly, to have some points of rebuttal for side proposition. Firstly, they mentioned a right to harm themselves, or referring to the terminally ill patients. However, note that if you're taking up experimental treatment, it's obviously you want to survive, to alleviate your pain, and it's also illogical that they are masochists, so your argument is not right to harm, but rather the right to choose. So they lose the ability of choice when A, they cannot possibly fathom the harm that they are inflicting onto themselves. For example, even if people in huge financial debt, loan sharks are still illegal because you cannot possibly imagine the continuous harassment and threat to be subjected to. So it's not even an informed decision in the first place. And they are unable to even control the extent of harm, because the inherent difference with drugs is because you're unable to choose things like the amount you consume, because this will affect efficacy and harms that are likely irreversible. As long as it is a medical treatment, the control of the extent of harm is in the company's hands, because they decide things like the concentration and dosage. And the exact purpose of safety trials is to shift this control back to the people by imposing regulation which reflects the interests of consumers of treatment, which is unanimously for it to be as safe as possible so that they can live. Secondly, side proposition also mentioned that they will only give them drugs close to the completion of trials. First of all, you're crossing the house, because by saying this, you inherently concede to the importance of safety trials. They undercut their own benefits, since the sole premise of removal of safety trials is to be speeding up the process. So their side has no significant decrease in the amount of time to access the treatment, because innovation is even slower as well because less people opt in for clinical trials. And without these safety trials, these these companies won't have enough data to call out companies, and there will be a decrease in reliability. So moving on to my setup. The policy of this argument is that government subsidies and palliative care will be supported, and we also have targeted grants and additional funding to promote research and development. So we have to clarify that this debate isn't about drug trials, because it is already a viable option in status quo, and it's inherent to the process of passing safety trials. So proposition has to defend people being able to consume these drugs outside of experimental procedures, like how they would for approved treatments. I'll explain these harms later on. So my first substantive on inability to consent. The premise here is that people can only consent to harms that they can reasonably understand. The mechanisms are, firstly, patients are likely not going to understand the harms because they are consenting to a lack of research that suggests that pharmaceutical companies won't be able to predict the side effects these treatments will bring about, and they won't be able to present the patients with the worst case scenarios or even give them meaningful odds for them to make an informed choice. So when a person has terminal illness, it's often the worst thing that's ever happened to them because they are actively literally dying. So as such, it is very hard for them to imagine or come to terms with anything even worse, because they feel like they'll be okay with the odds for most horrific things that will happen as a consequence. So an example about elephant man, this is because a drug was intended to boost immune health that was tested only on phase 1 in healthy humans, where the worst people affected lost his fingers and toes, and all the other participants were told that they will be likely to develop cancers or autoimmune disease as a result. So the link to our case here is that these patients are going to die anyway, but with these side effects, their death and mental state, their physical and mental state are likely to be deteriorated, and even if they live a month longer, this takes a toll because they'll be living in excruciating pain. So in this scenarios, patients are also likely to think that it's a good idea to take experimental drugs, because most people wouldn't have the knowledge about experimental drugs and treatments because they are often introduced to them by medical professionals. And because they think medical professionals are knowledgeable about healthcare, they're likely to buy into this. So why is this bad? Firstly, because all medical expenses are borne by the patient and the patient's families, because insurance companies aren't likely to cover insurance because of the uncertainty and the lack of research surrounding these experimental treatments. This is a direct rebuttal to what proposition said, because these patients and families are also unable to seek financial compensations in the form of lawsuits, because if not, then these pharmaceutical companies wouldn't even give them access to these drugs in the first place. In status quo, where we have safety trials, there will only be insurance for coverage for unwarranted side effects, because companies want people to feel safe and have an incentive to go for these clinical trials. But this is a precedent for companies to be able to market the drugs. And the patient's caretakers will also be inevitably affected. So secondly, on my harms to drug development. My second substantive on the harms to drug development. So the first premise is that in spite of risk, the allure of a higher chance of getting better means that terminally ill patients are less likely to volunteer for drug trials, and they will be likely to opt for full doses of experimental drugs taken outside of controlled environments instead. So what this means is that these drug trials are distinct from accessing experimental drugs, because drug trials involve 8 different phases. Dosages are always limited and administered based on the observed safety at the current phase. For example, preclinical phase, where they test on non-humans, and phase 1 test for whether the drug is compatible with the human body. It's a very basic form of testing, and phase 2 is where further testing of the drug is tested for efficacy. And part B, where specific controlled settings and environment won't be there. So will be that because this will reduce the likelihood of side effects that could be caused by other factors. However, on your side, on the house, there will be no professionals on site and in no proximity to control any abnormalities. And part C, because of the criteria for extent of ailment, for example, only healthy individuals will be tested for certain phases. And secondly, the data gathered from these terminally ill patients taking experimental drugs cannot be used for research and development of the drug, because there is a lack of regulation and systemic data collection means. So this means that there is no control factors, and you'll receive piecemeal data collection from patients that is unreliable and inconclusive. So the purpose for this drug trial is not to just exclude drugs that don't work, but also to get closer to developing drugs that do. So it's about minimizing significant third-party harm. And what this means is that insofar on proposition, you allow people access to the drug before it's completed drug trials, you leave the people around them and themselves face the brunt of the plethora of unpredictable side effects. For all these reasons, I am very proud to oppose. Thank you.
Okay, I think the second second opposition speaker, first opposition speaker for this speech. We'll now proceed to second speaker of proposition. Here.
Just to check that I am visible and audible.
Yep.
Okay, thank you. I will start my speech in 3, 2, 1. Judge, the structure of my speech today will be first into some rebuttals for the House today, then into my 2 arguments, and lastly followed with some impacts. So first, I'd like to go through the rebuttals we have. First, we'd like to bring up that opposition said that the control of the harm is in the company's hand. Even if this is correct, we believe there's no incentive for the companies to harm the terminally ill patients. And we actually believe that companies will try their best to minimize the harm as they want medical development and cannot take public backlash if they are really harmed the patients, explained by my first speaker over again. Oftentimes, drugs go through years of trials to ensure optimal safety. However, baseline safety testing, i.e. to ensure that the largest side effects doesn't occur, is often done in months. So the delta of time is still extremely large on our side. Second of all, they bring up the inability to consent, and so there's lack of research, no idea of side effects, worst case scenarios, leading to an uninformed choice. First, I'd like to bring up mitigation. There is at least some extent of information available in order for these drugs to be in operation in the first place. Basic information is already required. And on top of it, especially those regarding side effects and harms, which are the first thing developers test for. Second, oftentimes the effects and harms of drugs largely vary by person, even for normal drugs. There is no way to test for absolute information. And third, even if the decision is uninformed, it is still justified, given that these patients are experiencing crucifying pain and desperation. Their current state of pain already justifies the decision to fight for the hope of survival. Information and complete rationality doesn't matter given the dire situation. The pain justifies the decision in of itself. And then they bring up that they think medical experts are reliable and will trust what they say. These medical experts have an incentive to provide the best option for that patient. We still don't see what the incentive for medical experts to lie to them, as if things turn bad, there will be no public backlash from society. They're not going to gaslight them into thinking that there's a certain choice, because first, that goes against their code of conduct, and hospitals need to keep up their reputation, especially those patients and families would trust in those hospitals and companies with credibility. Secondly, experts to hope that these drugs work simply because it brings so much more benefits to a wider society. Experts get into this field of medical research to improve society, not to gaslight people and say, sign up for our drug even though we haven't gone through all the trials first. Now I'd like to move on and then note their counterfactual judge. Their alternative is literally death. Not only having their lives shortened, but the rest of their days are left in desperation and no hope, knowing them themselves are ailing and dying day by day. This alone is the worst scenario you can bring a person. Even if they experience side effects, we think firstly, we've given you multiple layers of analysis to prove why these side effects aren't going to be very large, as companies have an active incentive to control these, but also death is much worse than side effects in many statuses. And now I'd like to move on to my argument. First of all, safety trials take too long to complete. Safety trials take up to years to complete. Terminally sick patients have months at most. Sick patients don't have a lot of time and already don't have a high survival chance. Second, safety trials just diminish any last hope of saving them while only helping others 10 to 15 years down the line. There should be a heavier focus on saving lives of those currently sick and giving them a fighting chance. Long safety trials can't achieve this due to the time constraints and in turn nearly end up saving no one. On top of this, strict regulations exclude the sickest patients from access, so even the ones who need it the most don't get the treatment they deserve because of regulations around safety trials. Second, the risk is contextual and largely depends on the situation. Safety trials are focused around widespread population risk, not the terminal patients themselves. Terminal patients face almost certain and immediate decline. They do not face the same worries around side effects as the general population. Third, when death is almost certain, there is little regard for side effects if it means saving lives, which is also so much more important in the status quo. Third, there are safeguards in place to ensure that the decision made is ethical and well thought out. The decision to take experimental drugs is not a light one in any mean ways. There could be safeguards in place to ensure the safest way of taking them. Access would only be granted with doctor approval. and patients will receive full disclosure and informed consent, like my first speaker has already set up in framing. On our side of the house, we give people a fighting chance when they are already at their lowest. My second argument, medical research advancement. First, medical research is bottlenecked by lack of data from the sickest patients. Clinical trials are designed to minimize risk, not to maximize relevance. As a result, most trials doesn't exclude terminally ill patients. Second, participants are often younger, earlier stage with fewer complications on fewer medications. This creates a systematic data gap. Drugs are tested on bodies that do not resemble the bodies that most need these drugs. Second, by the time patients reach late-stage illness, there is no evidence base left to guide the treatment. This is a structural flaw in how research is conducted. Extremely sick patients respond differently to treatment, and that is a key difference and implication. Testing on relatively healthy patients cannot substitute testing on terminal patients. There are key biological differences, like organ damage, weakened immune systems, multiple interacting diseases. So this changes how drugs are metabolized, what dosages are affected, what side effects actually matter. And so when we allow the sickest patients to take these drugs, we get better drug refinement, better targeting, faster abandonment of ineffective resources. That is not reckless, that is efficient and ethical science, which we think is most important. So quickly, I'll just finish up with some impacts. Impact one, we have increased patient autonomy and dignity. And then second, we reduce suffering and improve the quality of life. And third, there are faster breakthroughs and fewer deaths in the long term, which is why I have never been so proud to propose. Thank you.
I thank the second speaker of proposition for that speech. I will now call upon the second speaker of side opposition to give their speech. You're here.
Can I confirm that I'm audible and visible?
Yes, you are.
Okay, just okay. I'll be starting my speech in 3, 2, 1. Proposition talks about how pharmaceutical companies have the incentive to not put out the random drugs that don't actually bring out any benefits. Few reasons why this is not true. Number one, pharma companies are profit incentivized. They're likely to price experimental drugs at a profit and also likely to ensure that they are legally protected before giving patients access to the drugs. From substantive one, they're unable to gauge the side effects that drugs will bring about. Pharmaceutical companies then stand to lose large amounts of money from patients suing for damages. The only way their side can claim their benefits is number one, they provide them with legal protection. This means that pharmaceutical companies have far less incentive to continue investing in drug trials. Because number one, they can save on costs and continue profiting from the same drugs with less work. All the standardization regulation with drug trials necessarily implies that they're more time-consuming, more costly in order to ensure scientific accuracy to provide reliable results. These costs don't exist when pharmaceutical companies are now able to give terminally ill patients access to drugs and profit off of it. The impacts of this is when fewer patients go for drug trials, and pharmaceutical companies are also disincentivized from running drug trials, drug research, and development is overall slowed down. This harms the ability to cure future patients who would have been able to access the developed drug had it passed future drug trials. They also talk about how pharmaceutical companies don't have the incentive to put out good drugs because they care about company rep. Note that logically, this makes no sense. The fact that they haven't been able to pass drugs and safety trials in of itself signals towards possible risks and side effects that companies cannot predict. If company reputation was truly enough of a concern to override profit, pharmaceutical companies wouldn't be really willing to release experimental drugs in the first place because of the increased risk. Therefore, your side cannot claim any of your aforementioned benefits. Even if on our side, a drug that already passed safety trials goes unexpectedly wrong, it's very easy for the company to just redirect the blame to the FDA. This does not exist on your side when the drug doesn't even fully pass FDA trials. The only way your side can claim such benefits is if companies are able to withhold such information from the general public, for example, through NDAs. Then they would be willing to release experimental treatments because it doesn't pose a risk to their general sales. This gives companies leeway to create bogus, and unsafe drugs and not experience any consequences. Moving on to another rebuttal is when they talk about how without this, people are dying. Note that death is not always the worst thing. Number one, death is inevitable, life and constant. It is bad that you're dependent. Bad is what you're dependent on and what you decide to put yourself through before you die. The decisions you make before death are finite. So if they choose experimental treatment, it's likely they won't be able to opt for other things like other treatments or palliative care. On their side, people commit themselves to something completely unpredictable and they don't even know when they will die. For example, paralysis, organ failure on top of death. Our side, we give them clear research and definite likelihood of improved quality of life before death, for example, palliative care, or give patients the active ability to make informed decisions of whether they want alternative treatment and give them a chance to control what little time they have before death. Another thing to also point out is how most treatments for terminally illnesses already have low survival rates. But I think at the very least, we're able to ensure the efficiency of this treatment to patients who choose to take the risk. Because we recognize the desperation might cloud a person's decision-making calculus. That's why we filter and only give access to drugs that can ensure basic efficiency. When you list out side effects and percentage of cure, this in of itself provides information for extremely desperate patients to make a more informed choice. Their side doesn't give them a clear chance of curing their illness and doesn't even give them clear side effects because there's a lack of research. This is just exploiting their desperate state of mind and doesn't allow them to accurately weigh the opinions. Okay, moving on to my last rebuttal is how they speed up drug development because more people are using it. They say, number one, they say that no safety trials on terminally ill patients. I think this is just not accurate at all because if you actually read up in phase 3 in safety trials, they actually tested it on an experiment on terminally ill patients. They're not being charitable to our side at all. Even if you have a miracle drug, you can just speed up development. For example, the COVID vaccine was made in 100 days because it was so good and it was in such demand. And also, no, we don't want more people to take on drugs in large doses, but only take on waste in experiments that are set, for example, clinical trials. We already proved how it's far less likely on your side. It's difficult to make sense of a multitude of information with no controlled factors. Even if take out the best case, somehow you're able to analyze all the info. Even if any side effects happen, it's also impossible to isolate causes to investigate because your administration doesn't happen in a controlled setting. For example, in the lab, you have stringent sanitization and clear bacteria. So therefore, outside of the lab, you cannot come up with accurate conclusions. The worst case is wrong data throws research off and is counterproductive in both efficiency and safety of treatment. Moving on to my stuff for today's debate, which is the fact that you erode drug safety standards. The premise of this is when you pass laws into society, the same principles that they're based on are often used to justify and create new laws. This means as long as proposition allows terminally ill patients to access experimental drugs, this creates legal precedents for reduced regulations on other types of experimental treatments. This is because firstly, terminally ill patients aren't the only ones desperate enough to be willing to access experimental drugs. The same sentiment extends to those, for example, with chronic pain or for athletes with lifelong injuries that render them unable to play professionally ever again. With this law in place, lawmakers are able to argue and justify expanding this program to include the lives of those people. For example, the right to try law in of itself branch off of existing extended access programs. Secondly, then, even if prop mandates that the drugs need to have passed at least one phase in safety trials, patients will eventually still be able to access them at earlier and more dangerous stages. The same principle applies here. Access is given early because they're desperate and short on time. Thus, in the future, they can justify giving them at an earlier stage. This is bad because this means society can access untested and unsafe drugs on a much larger scale. In perspective, 1.5 billion to 2 billion people experience chronic pain, and that's just one of the types of people who might opt in. This is on top of the fact that most experimental drugs they come across on the market will be the earliest possible stages to save money on clinical trials and earn more profit. This is even more unsafe and likely to result in side effects. This creates the erosion of drug safety standards, gives way to large-scale issues like the opioid crisis, which we're still seeing the effects of to this day. In 2023 alone, over 70,000 deaths happened in the US as a result of the opioid overdoses. Therefore, never prouder to oppose.
Okay, I think the second speaker of opposition for that speech. I now invite the third speaker of side proposition to take the stand and give their speech. Here.
Hello, just confirming that I am audible and visible.
Yeah, you are.
I'll start my speech in 3, 2, 1. Just the one thing that side opposition does not understand is that these patients are in deathly pain and they need this solution as soon as possible because this is an urgent issue. They have tried every single possible cure in the world, and we have already put that in the framing. They have tried every single option that is available to them, and that has not brought them anything, which is why we need this development and this treatment as soon as possible to support them. So I will present you with two clashes. The first one on the patients and how the drugs are going to affect them, and the second one on the drug development, and I'll provide you with some weighing. So first of all, my first class on patients. On their side, they have been pushing on how the drugs are not going to be actually beneficial for the patients because the companies are actually behind all these drugs that are controlling the harms. And on their side, they have like different phases, and on our side, we also have no time like that is actually cut down. And our side, we're telling you that the companies have the best incentive to actually support these people, as we've already put in this framing. And they have also mentioned that these companies are profit incentivized. We flip this because the only way companies can acquire profit is to build consumer trust, like we have already told you in our first speaker when we have been telling you that they need the reputation, right? And if the drugs are proven to be bad or unsafe, and they are not targeting the target audience, and the only target audience, which are terminally ill patients, they will lose large amounts of revenue, and they will not get any like investors to support them. And we believe that the public backlash is actually more harmful to the companies, as that will make them lose a lot more profit from a long-term scale, which with the public would just simply lose trust and stop opting into this company. And there's always a misconception. The way in which drug trials work is that first stage tests for harm and side effects, further trials only test for effectiveness and refinement, and to ensure full legality. And therefore, on our side, we actually prevent you with like a basic premise of actual the drug working. We only need basic refinement, as our first speaker has been pushing down the bench. And they also said that
information.
yes.
If your companies are so profit incentivized and they build profit by building trust, wouldn't it be likely that the companies would just send their drugs to safety trials on your side instead of just releasing it?
I don't get so the basic thing about safety trials is that we actually reduce most time for the patients, right? And as they want to target the patients that need this drug as soon as possible, this is basically why they provide these drugs to the patients, right? And on your side, you have also said that we have uninformed choice, and they don't understand the harms, and they just trust the medical professionals blindly. So we're telling you that these patients, they know about their own conditions, and they know about these medical terms, concepts better than most medical professionals, even because they have already went through every single possible cure. They have suffered for a long enough, and they know everything that has been happening in this industry because they are terminally ill, right? And I'll move on to the next point on lawsuits, etc. But then this will also happen to you on your side, so we don't think this is mutually exclusive. And they have been pushing that the death is not the worst thing, but here we want to clarify that terminally ill means that there are no existing treatments that can actually cure them, which means that they will die. And on there's a they have to prove that why the side effects are actually worse than death. But on our side, we have been already telling you since first speaker on proposition that there has been already some basic trials done, which means that they will not get the most deadly side effects and harms. And on there's they can get they cannot get cured because they have no time, and we give them the cure now. We actually prevent them from death, which is the final state, and we actually give them a chance to live, even if they might not live as happily as they were before they got the illness. But at least we provide them with a chance to get the cure. And now I'll move on to my second class on drug development. First of all, they said that it's really hard to control all of these, but then on our side, we're saying that there has already been basic development. And the medical people, they know what they're working with. And without data from the sickest patients, researchers are continuing to take blind shots in the dark. And excluding terminal patients slows innovation instead of protecting the people. And opposition claims safety trials protect the patients, but in reality, they take the future hypothetical patients and not the ones that actually need this right now in the world, and while actively sacrificing current real ones in the field. And because terminally patients are excluded, the companies will take 10 to 15 years to actually realize a drug doesn't work on the advanced illness, because the illness are going to take mutation, etc. through the time, and they will need reformation and need a different dosage, right? So there is the massive time and money wasted, and first of all, the investor won't like that either, and the companies are also going to be disincentivized to waste the money and the time, and potential breakthroughs are delayed and abandoned prematurely. And allowing access creates a real world evidence immediately of what works, what fails, for whom, and why. And these and this actually speeds up removing their last chance, and they will actually learn nothing new and help no one in the present, which is what is going to happen on site opposition. And they've also said that there's going to be deadly side effects, but that it's actually worse to test them on, like, for example, like rats, because there is no like biological like parallel between like a rat and a patient that has cancer, right? And this is and we're just adapting this to the people that actually need this, and therefore I'll move on to my weighing. So first of all, we are actually supporting future development because we are refining this onto the people and not on some lab animal. And we actually offer the patients to have a chance to live. Our main target here is to support the terminally ill patients. On their side, we don't think they're going to like give them much of a chance to cure when they're giving them like, oh, let's say, oh, wait 10 years and we will provide you with a safe drug that might not even work on them. And that is important that we save at least someone, even if we are sacrificing some people along the way. And this is actually more significant because, as you have said, and as you guys have not opposition has not proven why the side effects are going to be more deadly than deaths, then therefore the side effects are not going to have as much of a significance than curing and actually stopping the patients from dying. Thank you.
Hi, can I check that I'm audible and visible?
Yep.
Okay. I'll be beginning my speech in 3, 2, 1. Side proposition is really, they make a mistake in the sense that we're not saying that we're not going to develop drugs. We're just ensuring that these drugs are actually going to work before we allow people to access them. So proud to oppose. 3 main factors for my speech today. First of all, on how companies are going to act. Second of all, on the principle of whether or not these patients should be able to get these drugs, and third of all, on overall drug research and development. First, then, on how companies are going to act in either side, right? I think both sides agree that they have like a few main incentives on profit and on reputation. I think in terms of profit, right? I think we already tell you in our previous speakers that this drug, like there's an incentive for them to price the drug at higher than cost, and they're going to profit from this, right? And drug trials are often very costly, very time consuming. It takes a lot of time to slowly like find out details and make sure there's no side effects that are going to impact people, right? These are things that they don't have to do on-site proposition when you're able to just give out the drugs. We're just able to give people access to the drugs. I think there's where companies have an incentive to like, I think that is where companies have the incentive to do this, right? But second of all, reputation, I think that in terms of on-site proposition, right? I think given that there is like, I think we've proven to you that it's likely that they're going to have legal immunity because otherwise they wouldn't be willing to push this policy. I think that is where like companies are still going to be exploitative because they know that like people can't file them for lawsuits. They know that their reputation is going to be safe and sound regardless of the side effects. Third of all, then on the substantive that we told you in our second speak on this setting like a legal precedent, I think it's likely that on their side, companies are going to use this law and have more and more groups of people have access to these kinds of drugs. I think that we already mechanized to you. There are many people who are very desperate for this, and because principally it operates on similar principles to their policy, this is an inevitable thing that's going to happen on site proposition. You never deal with this, but I think this is very harmful, right? Because that is where you have things like these experimental drugs, like many groups of people having access to these experimental drugs that will prove to you later that like aren't guaranteed to be safe at all. That's where you have things like the opioid crisis. That's where you have people like that's where you have these very dangerous drugs, right? These risky drugs being handed out to like several groups of people. Second clash then on the principle on whether or not it's principally justified for these patients to get the drug. First of all, on whether informed choice exists. I think that on-site proposition operates on a premise that these doctors will inform these patients of all the risks that comes with these drugs. But the reality is that you literally cannot be fully aware of these risks because like I think you have informed choice. Yes.
Isn't it the exact same on your side when you're not even testing these on the patients? Because you have no idea how it's gonna work on their anatomy.
That's where we're going to have drug trials to make sure that we test these on like different kinds of people with different biological makeups. That is where we know the different kinds of side effects, so that when we finally push out the drug, they can have an informed choice on how safe it's going to be, right? I think that compared to other kinds of treatments where, for example, your doctors can tell you for sure that there's like a 90% chance of the surgery failing, you do not have these with these experimental drugs because you simply have not tried everything yet. You don't know how it's going to affect different groups of people. And like also these
these patients also aren't going to be able to be aware of like what exactly is going to happen to them. I don't think they're fully often aware of their own condition. They don't know what can happen. They can't fathom the kinds of side effects that could happen to them. Doctors don't know for sure either. That is where you don't have informed choice. That is where you are making these patients gamble with their lives, right? But secondly, is that the worst thing to happen to these patients? I think that we'd already tell you in proposition these patients might be facing unfathomable amounts of pain. I think that like it is worse when your eyes feel like they're falling out, your brain feels like it's on fire, as compared to when you're able to have things like palliative care or alternative forms of treatment on our side that we want these people to invest in instead. And furthermore, we already tell you in first, and they never deal with this either, on-site proposition, because of how costly these experimental drugs are. When after these people face all these side effects, there's also no way for them to solve it. There's no way for them to turn to alternative treatment. There's no way for them to have palliative care. These are all very expensive alternatives, and therefore they're all mutually exclusive. There's only one of these that you can go for. And on our side, we much rather that you go for these things that are guaranteed to at the very least make sure that your death is a bit more painless, it's more dignified. I think that is where like death really isn't the worst thing that could happen. The worst thing is when you are stuck, even if it extends your life by a little bit, those few months are spent in unfathomable amounts of pain. So a bit of weighing that. So I think very importantly, this clash is not about whether the drugs will work, right? But even if we want to deal with that, even if like on the best case scenario, they're able to find a miracle drug, I think this is parallel on our side, right? Because if the drug works so well, there are no side effects whatsoever and just like completely clears the illness, that is where you would have the same kind of effect on your drug trials. That is where your drug trials would be much quicker because there are no complications. The reason why drug trials are so slow, as they tell us, is because you have side effects pop up and you have to rework the drug. That is where so in that best case scenario, I think it's a parallel benefit on our side. But in the worst case scenario, when a drug doesn't work, that is where their side loses out, right? Because on top of these people having to deal with their terminal illness that you can't fix, you now also give them additional amounts of pain from all these side effects that they also cannot fix because they just simply cannot afford to do any other kinds of treatment after that. So that's why I think principally it's still unjust for these patients to turn to accessing these experimental drugs. Second clash then on drug research and development. I think this directly comes into the second substantive on the idea that drug trials, because you tested on healthy people and you did it in small doses, is therefore inaccurate. I think we do this because when you have these drug trials in like smaller doses in a controlled environment, that is where you're instantly able to contain your side effects and prevent this person from being in large amounts of pain, right? I think this is necessary when you're trialing these experimental drugs because you do not know how bad the harms can be. When you do not know, it's much better that you're able to protect this person to some extent because you have a controlled environment, you have small doses, and this person is at the very least already healthy, so it's not as bad for them. I think it's much worse when you have these side effects on like these terminally ill patients because of everything that they're already going through. But second of all, on their side, the data that they get is very piecemeal, right? Because these are not drug trials. When you give these patients access, they're taking the drug full dosage, and you cannot have this controlled environment. You cannot have you cannot make sure that the side effects come from the drug itself. We actually want to be able to develop the drug. And this only happens when you have actual research, actual data, and actual drug trials. Never been harder to oppose. Thank you.
Okay, I think the third opposition speaker for that speech, I believe this is the same format as the SSSDC. So do I give you guys a 2-minute break between reply? Okay, I'm gonna assume that's a yes, and I'm gonna start your 2 minutes now. Okay, your 2 minutes is up. I will now call upon the opposition reply speaker to wrap up the case for the side of opposition. Here.
Hello, may I check that I'm audible and visible?
Yes, you are.
Okay. I'd like to start my speech in 3, 2, 1. So I'd like to clarify, I'm sorry, not to clarify, but I'd like to just bring the debate together as a whole with these few arguments that both sides have. So firstly, on the principle of patient trust and hope and whatnot. So they mentioned that informed choice is existing on their side. However, this is simply not true, as we have told you from many benches down already. This is because there is a lack of they say that they have consumer trust, but this is inherently untrue in the first place, because this accountability they claim that there is an accountability that these companies have to respond to. However, this is not true, because this accountability data comes from the data of safety trials in the first place. And note that the reputation doesn't even matter, because proposition themselves say that patients are desperate. So therefore, they don't have an informed choice, because there is no need for trust, because there is an inherent this trust and that the drug is inherently untrustworthy because it is unknown on their side of the house. They also make a contradiction and say that patients and professionals know what is possible to come, and therefore they opt in. However, this is simply not true, because the patients and the professionals themselves don't even know what happens to the drug on these patients themselves. And on proposition, their side can claim plausible deniability. Note that this is never going to be note that these companies are never going to be able to help reliable, because this accountability data simply comes from the data of safety trials. And next, they mentioned how our drug trials are too slow, and there is a lack of research and development on our side. However, note that they also mention a lot of things about reputation, but this erodes drug treatments because it creates loopholes, and thus these companies can have unethical guidelines because of a lack of legal precedents, where on their side, we have already proven they don't have lawsuits, and insurance can't cover these patients. So what this means is that these companies can exploit this uncertainty and lead to a lot of things. For example, the opioid crisis, which we have told you why it's so bad. So I like to now weigh this on likelihood, because proposition, there is a high likelihood of exploitation and scale, because they make a contradiction as well, because on outside of the house, we have more trials. They claim that drug trials are ineffective, and they cannot claim this benefit because of their baseline trials that they mentioned in their first. They can only claim this benefit if they concede that these trials work in the first place, which is inherently crossing the house. And the problem they have isn't about principally safety trials, it's about time and speed of what they have been pushing to us. Note that we already give on our policy, we give them things like subsidies, which will be able to speed these safety trials up, and with better technology. And we do it better with more people opting for clinical trials to develop the drug faster and make it safe faster. So people just opt for experimental treatments on their side, and that makes it zero incentive for them to have safety trials in the first place. Thus, they cannot claim any of the benefits that I have mentioned. Recognize the inherent harm of zero safety trials is that we don't concede to subjecting our most vulnerable stakeholders to even more harm. And on their side of the house, they have so many more loopholes and things that their companies can exploit, leading to more patient harm. For all these reasons, we are very proud to oppose. Thank you.
Okay. Proposition reply.
Hi, sorry, adjusting. Am I audible and visible?
Yes.
Okay, so I will start my speech in 3, 2, 1. Judge, throughout this debate, opposition is completely off, ignoring our framing and all the mechanism which all my third speaker, including me, have provided so hard and explained so many times. First of all, let's quickly go through the debate. Their argument was about uninformed choice and which they explain as a harm that is controlled as because the harm is controlled by companies' hands. While we've rebutted how even if this is true, companies are not incentivized to provide terminally ill patients with the completely fresh drugs as they are scarce, and the company aimed to develop the right cure for profit reason and the fear of public backlash. Then on our arguments, we explain about chance and hopes. Like mentioned throughout the debate, we provide a chance and hope for the patients. Companies are incentivized to develop treatment with the baseline safety so they could better develop the cures. And we also mentioned how safety trials take too long to complete, 10 to 15 years is saving hypothetical future patients, not the only ones currently suffering with no hope left. We explained how there are safety measures in places that isn't a decision to be taken lightly. We also explained that medical research is currently bottlenecked by the lack of data regarding to the sickest patients. Patients in safety trials are young, on fewer medications, early stage of illness, etc. Hence, drugs often don't work on those who need it the most, and which is why we need to get rid of these long safety trials that serve no one. Now, quickly moving on to my weighings. Let's simply compare the two worlds at the start. On opposition's world, ill patients will only be allowed to access treatment once those treatments have passed the long taken 10 to 15 years of trials, which at this point, there won't be even the terminally ill patients as before, because there will be mutations happening and they will even get sicker while just waiting, or most of them might just die because they don't have time left. Currently, terminally ill patients and the future terminally ill patients won't be able to find a cure because, well, they will never be able to get a chance to get a cure, or even a chance to try on experimental cures as soon as possible, as they don't have time. They are dying, which means people just die in opposition's world. While in proposition's world, terminally ill patients get a chance to survive and contribute to medical advancements by their own choice. Families of permanently ill patients will also gain closure knowing that they really tried all the options, which reduce long-term guilt and emotional traumas for the families. We also have medical breakthrough. And as most treatment have already passed early trials, the chance of benefiting from these treatment is real, while harm does not significantly worsen an already terminal conditions. Therefore, the risk is actually most likely rational and proportionate. We've mentioned the word terminally for so many times, but options keep dropping. What is the real definition of terminally? Which means there are no existing cure in the world. That's why we're giving them a chance for those experimenting ones. Then the recovery will be a bigger scale of benefit than side effects on the patients as they were already terminally sick. And these side effects will not have much of an impact of them compared to the recovery. Therefore, we trade it off, as even if we don't have side effects, the impact of recovery is much greater and significant. Saving or extending a meaningful life clearly outweighs temporary or additional terms in opposition's world. To end this speech, opposition is just forcing people who are already dying to wait for a system that's just not even designed to save them. When the choice is between guaranteed death and a chance for life, I think it is already very clear that the proposition clearly wins this debate, as we are truly benefiting not only medical advancement and also the most important stakeholders here, the patients. Thank you. And that's why I'm so proud to propose.
Okay, I thank both teams for the debate.